So now I think it's really over, going to go over to Julie to ask her to read out some of the questions. I'm going to leave the model up on the screen because that might help some of our chat around it.
Lovely, thanks Alex. Well, there's been a lot of discussion in the chat box here. I've got a lot of questions that I have to put to the panel. So I'm just going to get started, starting at the top and working our way down. First of all, Simon Harris asks, do you equate post-stroke development as equivalent to physio, as been implicit in the audio so far?
As a physio, as in physiotherapy. So no, I think not. And one of the, we've grappled with the title for this review over the last couple of years, because it did very much, as you saw from the history of it, it started in 1999 as a physiotherapy review and probably was quite UK centric and quite Western viewed. And then as it's evolved, we've realized that physical rehabilitation around the world is not necessarily delivered by physiotherapists. So for example, in China, we have a lot of rehabilitation nursing, and so rehabilitation is being delivered by nurses within stroke units. So we are trying to avoid the physio. I'm aware probably my language is that I have probably ended up using physio as an abbreviation for physical rehabilitation, but we are keen that this is a review on physical rehabilitation delivered by any health professional, regardless of whether that's a physiotherapist or some other form of rehabilitation professional.
Thanks, Alex. I'm just noticing that some of the participants are looking for the more detailed slides so they can see the modalities there.
Okay, I'll underneath. Just scroll up through my slides. Yeah.
Thanks, Alex. On to the next question. Did you consider having OT involvement? Claire says, we work in an integrated way and feel that physical rehabilitation is delivered by both OTs and physios.
Yes, I agree. And yes, we did. And we deliberately advertised for not just for physiotherapists. So we deliberately said health professionals working in physical rehabilitation. And we didn't get any OTs who applied to join the group. That might be a sort of criticism of how we cascaded out, and possibly we had better physio networks than OT networks. But we did go UK wide and try not just to be completely physiocentric, and we would have definitely have had OTs on the group. And one of our reasons in terms of this group we've advertised it more widely and tried to extend beyond advertising it just to physios, because we do want those views, and we'd really value views from OTs and other health professionals in terms of how this model fits with their understanding of physical rehabilitation.
Thanks, Alex. Okay, John, the next few questions are about the stakeholders that were involved. Johnny asks, would the experience from stakeholders be different for patients with different socioeconomic backgrounds? Did you have this in mind when looking for stakeholders?
Jill, were you going to answer that?
Yes, I was going to say we didn't specifically ask for socioeconomic status. So yes, we would accept that it might be very different, but we tried to cascade the adverts as widely as we could, but we didn't factor in, you know, that we were looking at different socioeconomic status. We didn't ask that question.
And you know, I think clearly any consumer involvement like this, you know, this is an issue that Cochrane's got. We're relying on people who are seeing these things in social media or through their networks, which is probably a particular sort of person. So we probably are limiting, and the fact that we've done this all virtually and no attempt to have face-to-face meetings, which has been because of COVID rather than anything else, has probably limited our ability to engage with some audiences or some potential stakeholders.
Thanks, Alex. Simon asks, was the stakeholder group mainly Scottish, as he believes that here in Scotland we have the worst outcomes in stroke in Europe, and your review may not see the best as a result?
So no, it was not Scottish. So it was UK wide, and geographical location was one of the factors that we selected on. So we have got representation from across the UK.
I think, just to add to that, I think in the vignettes, it may be that because stakeholders did not have to do a video, we just asked if people were prepared to do a video. And I think 2 of the participants who said yes were Scottish. So it maybe looks a bit skewed, but certainly when we have the full stakeholder meeting, it's not full of people from Scotland.
Good point, Alex. Jill, thank you. Now Andre asks, will the model consider different degrees in stroke severity, age and or patient profiles?
So I think not the model, but those are certainly things that we consider within the Cochrane review. So initial impairment, for example, is something that we have always planned and always had within the Cochrane review as a subgroup analysis. Clearly, that's something really important in terms of how people might respond to treatment and the outcomes they might have.
Thank you. And next is a question about where the model can be accessed. Richard has explained that the review itself will be published in the Cochrane Library. Do you plan to make the model accessible before then? And if so, where will it be?
So that's a good question, which so the model is, I'm hoping that we get feedback today. So I think what's on the screen now is not a final version. So we have been developing it iteratively, and I am keen to go through all the comments that I haven't looked. I haven't got the chat open, and look at what's missing. So it is, as one of our stakeholders said, an active model, and we would like to update it following this stakeholder meeting, and then we also have another one in a different time zone in a couple of days' time. So we will update it, and it will be published in the Cochrane Review, and I think within our university web pages we could create access to it there as well. It might not be immediate because we have a whole list of review tasks to do and another 10,000 papers to screen, but yeah, it will be made available.
Great, thanks, Alex. Now, Andre asks about having the assessment and monitoring. He feels it should not be related to function, walking and mobility, relating to outcomes in real life. I just wondered if you had any comments on that.
So I wonder if that's a point about where it pointing into functional task training. Yeah. So I think maybe the arrow goes the wrong way. Feel free to people to comment on that in the chat. I think speaking on behalf of the stakeholders, they felt that the types of assessment and regular monitoring that the physio, for want of another word, is doing is important then in the selection of rehabilitation techniques. So whether somebody, say for example, is having a detailed biomechanical assessment of their walking done, is going to impact then on the functional task training that the physio might do with the patient. So that was some of the thinking behind that, but I'm completely open to people saying, no, actually that purple arrow goes the wrong way, and it, please tell me how you think it should fit together, acknowledging the fact that our stakeholders have told us that assessment and monitoring is an important part and should be considered when we're thinking about physical rehabilitation.
So if you're looking for somebody to comment on that, do you want them to contact you via email, or do you want them to put the information in the text chat just now?
Either, it's absolutely fine. Yeah, my email's on the final slide, so I'll get to that if they haven't got it.
Lovely, and I can add that to the text chat later as well. Thanks. Simon had a question about the model. So does the model address the client's challenges in integrating the intervention offered by all of the disparate disciplines and their understanding and where in the journey the stroke survivor is?
That's a good question. I think probably not, but I'm not sure whether that's not what it's aiming to do, because the model is very focused on the fact that we're looking at the targets of function, walking, mobility. So I mean, I suppose you could, with that question, makes me think this model almost sits within as a little thing within a much bigger model of the whole of rehabilitation. So we've taken the target of function, walking, mobility, and that's probably just part of a much bigger jigsaw. So I don't know if he wants to respond to that in the chat or whether he agrees or not, but yeah.
That might link to another question
Yeah.
that Simon had that I was just going to come on to, and he asks, what are the pros and cons of considering physio and OT in isolation from eating, speech, language, cognition, emotion, money worries, remote rehab, etc., all the other things that stroke survivors have to consider?
I think from a stroke survivor's point of view, I'm thinking to some of our stakeholders and what they've said, that they don't see it as separate, and really that's sort of picking up on a lot of the discussion around the need for psychological support and adjusting to life after stroke and the importance of that, which absolutely relates to the things that you've just said. But in terms of, with my sort of Cochrane hat on and my author hat on, and trying to produce different layers of evidence as to how we should go about providing the best possible rehabilitation, I think it would be impossible to print all those things. You think, well, at the moment we've got a basket of fruit. I think they're starting to talk about a supermarket. You haven't just got the fruit, you've got everything else surrounding it, which would be an enormous review. This is going to be an enormous review. And at the moment we're looking like we've probably got 300 or 400 trials that are looking at these sort of interventions that we'll be bringing together. So if you start to expand it into other interventions, for all that might be, I can see it from a stroke survivor's point of view, it's very difficult to separate these things. But in terms of being a researcher, I think at some point we have to put parameters around it to make it achievable for us to be able to synthesize this evidence.
Thank you, Alex. Ali had a question about intensity and dosage. It says, is the intensity and dosage of these components addressed as a component or mechanism of action, or is it a variable?
It is a variable. I'm just think we did subgroup analysis in the last version based on dose, and we divided the studies according to the dose. So yes, we explored whether dose had a role in the outcomes within the review. There is also another separate Cochrane review of the amount of rehabilitation. So that would be one to point you in the direction if you haven't seen it, if you're particularly interested in dose. So we explore dose in terms of physical rehabilitation, the amount that is delivered in these trials. But there is another one which specifically looks and would look at the trials that look at more physio versus less physio, or more OT versus less OT.
Lovely, thank you. There's lots of comments coming through in the chat, which we're thankfully going to get a copy of for after the webinar. I'm going to try and scroll through to get a question. Next one I can see here is from Leslie, who's asking, is physical rehabilitation not everyone's role or business? She's put nurse, OT, physio, assistant, HP practitioners, nursing assistants, stroke survivor, family members, and so on. I can see the use of specific physical interventions may be the remit of certain professionals, but not physical rehabilitation in general. Maybe it's just the language you use. Do you want to comment on that?
I think I probably agree that it probably is the language that I'm using, and I think I agree with that statement, that it is the business of everyone. But what we are trying to do as Cochrane review authors is pull together the evidence of what rehabilitation professionals can do to help support people have best outcomes. So this would be the sort of more formal physical rehabilitation delivered by a health professional. Now, possibly that support by the family members and by the nursing staff and the assistants, we are going to pick up on that in this version of review. Possibly that's the more important factor rather than the 30 minutes with the physio. But the focus of this review is that sort of rehabilitation professional input.
Thanks, Alex. Simon asks, is the target client outcome just walking?
It's not just walking. So we have got a limited number of outcome measures within this review, which is sort of in line with Cochrane policy of not having hundreds and hundreds. So it is walking and balance and motor function. So we've got things to, I don't know whether Jill, you can correct me off the top of my head, but yeah, ADL, so activities of daily living, measures of activities of daily living, measures of walking, measures of balance, adverse events, and measures of motor function. That's off the top of my head. Those are the sort of core outcomes that the review covers.
Lower limb motor function, lower limb and trunk motor function, not upper limb.
Not
There's a
upper-
number of separate Cochrane reviews that specifically focus on upper limb.
Yeah.
Thank you. Andre asks, didn't you consider vocational rehabilitation also in interventions addressing other stroke-related problems?
Yes, we did, and it should be on that list. If it's not, I've missed it off. We certainly have had conversations with the stakeholders. Possibly it's in our list of definitions underneath. It might be in that signposting one, but yes, we've had conversations about vocational rehabilitation. Our stakeholders have raised that, and it's definitely included. I can see it's not on that page as a term, but it is definitely within our definitions.
Thanks, Alex. Now we've got to the end of the questions as I can see them, but if anybody would like to ask any more, please just add them to the chat. But in the meantime, I'm just going to go through the comments to illustrate what things people are coming up with that should be added. You might be able to say it's already in there, or we can take a note of it for addition. Okay, thanks to Shamir, who says variance in MDT structure, quality and access of resources appear to impact significantly on patient outcomes. However, I'm not sure how this would be included within a study such as this. Furthermore, representation of more dependent stakeholders such as care, nursing home residents is important, but again, would be potentially challenging to facilitate inclusion, which is a fair point. Other interventions, can we add bladder and bowel, balance assessment, fall risk assessment?
Yes, they're probably, included within the definitions, in that we have got, in the other stroke-related problems, certainly things like bladder and bowel would be part of that. But yeah, we could certainly make sure that we specifically mention them if we haven't already.
Thank you. And Natalie agrees with this, including balance and falls. And she's also added include vestibular assessment and vestibular rehabilitation, especially for cerebellar strokes.
Yep, thank you.
And also ulcerative sensory assessment and re-education.
Yeah, so I think the sensory re-education is in there somewhere, but yeah, we'll check on that one as well. Thank you.
Lovely, thank you. At the moment, we've got 3 questions about how the stakeholder group was developed.
Yep.
First of all, from Praveen Kumar, Praveen. Given that stroke can be so varied and also experiences are varied, what number of stakeholders is sufficient or right to get insight into this complex topic? And he says, for RCTs, we refer to sample size calculations. Is this considered with engagement such as this?
That's a really, really good point, and one that we've discussed so much. So at the moment, there is no right or wrong, and there's no evidence in terms of stakeholder involvement, in terms of the numbers. We have done a review a few years ago of the sort of stakeholder involvement that people have done in reviews, and it varies hugely. Obviously, most reviews have no one involved, so normally it's 0. Some people have held big stakeholder events, and others have done small group things like us. Our 15 was based on the fact of evidence to do with how focus groups work and those discussions. If you go any more than 15, it gets very difficult to hear the different voices, but it is an area where there's no evidence. So yeah, there isn't a right or wrong answer. Our decision to hold these webinars was also based on that. So we were aware that we potentially had a limited number of stroke voices, and carer voices and physio voices within those 15. So that was why we've planned to do these larger webinars and throw it open and hopefully gain some of those other voices into the discussion. But we're learning as we're going along. It's still a new and novel thing to do with the Cochrane Review.
Can I just add that I think that we have been absolutely genuine in hearing the stakeholders' voice, and the stakeholders do drive our activities and our discussions and our thoughts. It's not a token stakeholder. There's a high level of involvement, which is really interesting for all of us involved in the group.
Thank you, Jill. Praveen has another question. What was the geographical variation of stakeholders? Were they all from the UK or international too?
So,
No, go, yep.
So they were all from the UK. That was what was planned. Although the video vignettes sort of show a bit of a Scottish slant, that's just the people that volunteered. People didn't obviously have to participate in making a vignette. And we had 2 people from Scotland, but we have got people from the Highlands right down to the south coast of England. So it's not a Scottish centric. But it is UK based, it's not international, but as Alex said, that's why we've got these webinars, so that we can, hear a wider voice.
Thank you, Jill. Praveen had another question. Could you please clarify if the stakeholders were included from ethnic backgrounds?
So yes, we have got stakeholders from ethnic backgrounds. We didn't actually sample on ethnic background. When you're a little bit like primary research, when you're sampling to have a group, we had so many factors we were interested in getting sort of distribution of. So the geographical area, the experience of stroke, whether that was as a stroke survivor or carer or physio, their years of involvement as stroke survivors. So we have, I think, got a relatively varied group, but that's probably more luck than intention. Yeah, we haven't captured that in terms of data. We haven't asked people formally about their background.
Thanks, Alex. Felicity's got a question. Where do you see things like therapeutic alliance giving the growing evidence for its role in outcomes?
I think that's another sort of wider area, isn't it, in terms of almost surrounding this model. I think we've had lots of discussions about how big and complex one review can start to be. Can you cover everything? So I suppose if there's a particular approach like therapeutic alliance, again, a little bit like our single apples and bananas, you probably want to explore that and get evidence for that as well as integrated. So it's certainly something, we could capture if people were saying that they had specific techniques like that as part of their rehabilitation, but it wouldn't be the focus of, of our analyses. But we would be able to capture if something like that was felt to be an important part of the rehabilitation process.
Thanks, Alex. Now on to some comments that are coming through that I think you'll be quite interested in. Andy McKellar says, diet and vascular disease management is missing. That's ironic given the foot analogy. Vascular disease is almost exclusively diet related, and just because the singular vascular event has passed, sidestep the concept that addressing the disease could influence rehab. So that was a comment more than a question, but I thought you'd be interested.
Yeah, no, that is important. I think possibly I need to update the slide because I think our stakeholders have also come up with some additional things in those interventions addressing other stroke-related problems. So, maybe stroke-related problem is not right terminology in terms of diet, but I think that definitely comes into that box of other really important factors that could influence the outcome.
Okay, thank you. And Emily Griffin says, it's great to see these complexities being addressed rather than ignored. I'm keen to understand more about how this model can be used in the review, given all the moving parts. Now,
do you want me to say a bit about that?
Yeah, sure.
So at the next stage, we've just identified, or in the process of identifying the trials that will go into the review. So what you see on the screen just now, each of those little components we're going to have in an enormous spreadsheet. So each one will become a row of a column of the spreadsheet, and then we will tick off whether they're included within the interventions within each of the trials. So we will have that big overview picture of the components. There's going to be an issue with reporting, but we will know when there's positively something that was there.
Thanks, Alex. Now, Sophia's got an interesting comment. I'd love to see outdoor rehabilitation in nature, physical activities, adapted physical exercise in green spaces, walking in green spaces, cycling, horse riding, climbing, and blue spaces, swimming, adapted surf therapy, adapted bodyboard explored for stroke patients.
Yeah, that's an interesting point. So there's two things there. There's the outdoor stuff, and then there's the other sort of functional tasks. We did have discussion about, how far you go in terms of those functional tasks. Do we have swimming, cycling, bodyboarding all in that box? We haven't at the moment. We would get a tick in functional task training there, but we wouldn't maybe capture the specific thing. And I guess if we found a series of trials that were all looking at the same thing, then we maybe need to go back and retrospectively add in so that we can group those together. The outdoor space one is an interesting one, and I wonder where that fits in the model. Speaking personally, to me, it'd be a big cognitive information processing. It's a motivating factor, isn't it? But whether that's the right place for everyone, I'm not sure. Comments welcome.
Lovely. There's lots of comments and questions coming in, so I'm going to pick out the questions next. Leslie Ann Rollins asks, will you be doing a similar stakeholder-based Cochrane review for upper limb physical rehabilitation in the future?
So not a similar review. So for the upper limb, there are lots and lots of individual reviews on all the different types of things that might be done for the upper limb. And then there has been an overview, which actually I was involved in leading. So there's an overview of the upper limb reviews, which did have some stakeholder involvement, but not nearly as comprehensive as this. That probably needs updating. So that's probably what we should do. We should probably ensure that we have stakeholder involvement in an update of that review. Obviously, that's dependent on resources, but I would love to do that.
Great, thank you, Alex. Sarah Plant asks, I'm interested in why only physiotherapists were involved in the stakeholder group and not occupational therapists.
Well, so am I. So we advertised for anyone who was interested in physical rehabilitation, and we didn't state profession. We only got physiotherapists who applied. Now, whether that was because of where we circulated out, we tried to be as wide as possible and did go out through OT routes as well as physio routes, but only got physios who applied and were interested in being involved. So I'm hoping that these webinars have enabled us to get people who are not physios but are other health professionals, so we are getting that voice. But any thoughts about how to engage other groups more in the future would be welcome as well.
Thanks, Alex. Jen Alexander asks, is fatigue part of the model? Learning to manage fatigue along with physical rehab, which can exacerbate fatigue, seems to be an essential component to successful physical rehab.
That is a very good point, and I don't think we have had discussions about fatigue, and I agree that fatigue management should be in there somewhere. So yeah, thank you. Good point.
Okay, thank you. Now, Jennifer Nisbet asks, will duration of treatment be included, i.e. time post-stroke?
Yes, I didn't mention that because that was one of the original analyses and subgroup analyses right from the start of the review. So duration and length of treatment and dose of treatment are part of the analyses that we do.
Thanks, Alex. Now I'm just going to go to some comments just in case you want to elaborate where people are saying they think things might be missing. You might know where they already sit or if they need to be added. So Leanne Carey asks or says, appears to be missing ingredients related to discrimination of touch, proprioception and other functions. Do you have a comment on that?
So I'm trying to think where the sensory stuff fits. We certainly do. That's an interesting point because we do have interventions clearly that are included that do include lots of sensory motor. That's one that we need to go back and look at. Yep, thank you.
Thanks. And Catherine Trumpy, I hope I've pronounced that properly, Catherine. There's just one item that I think is missing in this module, the time that the patients got from the physical therapist or the whole functional rehabilitation. I mean, the insurance paid different amounts of time depending on the country, which is an interesting international perspective.
Yeah, so time is dealt with separately, and it's has always been an important part because clearly the amount of physiotherapy is going to be absolutely central. There is also another review, a separate review that specifically looks at the time spent in rehabilitation. So trials that compare more rehabilitation with less rehabilitation as opposed to the different types of rehabilitation. They would be included in that one. So that might be an important review if she's interested in that topic.
Lovely. And then Praveen was adding in to the comment about diet, adding in stress, fatigue, pharmacy should also be considered there. And great to see emotional support being recognised as well.
That's fantastic. All good points. Thank you.
Yeah. Natalie Jones was saying, I was thinking about vocational rehab as part of functional task training. Don't know if you have vocational rehab.
Yes, vocational rehab is, and it's a typo to miss it. So this was one of, I think I must have got an old version up on the slide. So our stakeholders identified vocational rehab. It came up in the last webinar and I went back and checked, and it is now listed along with occupational therapy and vocational rehab. So it is in there now.
Great. And Natalie's making a suggestion that perhaps when contextual real world walking included could perhaps be a subsection of walking practice, perhaps.
Yep, that's a good suggestion. Thank you.
Okay. And talking about supported self-management, Kitty says, I see that it's mentioned, but I wonder whether there may be a need to consider more explicit link to translation of real life context, community and re-engagement. So linking into this idea of outdoor space as well.
Yes. Yeah, it starts, I mean, there's so many things that we could do, isn't there? And I suppose the challenge then becomes how much the trials will have reported as well. But I guess if we have a model like this, then it hopefully starts to encourage trialists to report these elements of physiotherapy, which maybe traditionally have not been reported.
Thanks, Alex. And Jen Alexander points out, what about transference of skills gained during formal therapy into real life?
So in terms of our outcome measures, we do look at activities of daily living as one of the outcome measures, and obviously measures of walking and balance. So I guess that maybe transfer is possibly more linked into outcome measure, although maybe she's referring to practice of transfer of skills.
Yeah, Jen, if you want to clarify that, feel free to add another message in the chat. 2 questions now. Anthony Peacock asks, will there be a future Cochrane review looking at the same model of rehabilitation care with paediatric stroke?
I can't answer that question because I'm not involved in the reviews on paediatrics. And certainly I think if that's something you think is important, then you need to propose it to the relevant Cochrane group.
Thank you. And Philip Wright asks, I may have missed this, but would mirror therapy for improved limb function be included anywhere?
So it's not listed as a modality. So that certainly should be listed as a modality. Again, mirror therapy, we're treating as a sort of, a component. And yes, we would note whether it was used. There are lots and lots of trials specifically just focused on mirror therapy, and there is a separate Cochrane review of mirror therapy. So when it's just mirror therapy that's being compared with something else, then that wouldn't be included in this review, and it is in the other review.
Thank you. And Praveen asks, is driving considered?
Driving is not currently on the list, and I suppose our focus is function, walking, mobility. It's functional mobility, it's not driving in a car mobility. I'm not sure, we'll take that onto our stakeholders and see whether they think it's appropriate to have that in. I'm not sure what you think, Jill. I don't know, possibly it's going a step too far.
I'm wondering the complexities of this review and trying to work out how that fits to physical rehabilitation approaches. I suppose it could be argued both ways, but I think it might be difficult to see how it fits in. But I think we should have the discussion with the stakeholders, because we're just one viewpoint.
Yeah, I mean, I think actually, one of the criteria for a study to be included in this review is that it's aiming to improve function, walking, mobility, and I suspect that interventions that are aiming to improve driving will not have the focus that we're looking for. There is another review on interventions to improve driving, which obviously then includes all sorts of other things, because it includes perceptual difficulties and visual difficulties as well.
Thank you. Jen's come back to clarify this idea of how you incorporate into real life. She says, I mean that it's essential component of physical rehab is helping folk to actively or consciously incorporate physical skills gained in therapy into real life. It doesn't just happen, and it seems to limit benefit if it doesn't change life. And we had a question here from Natalie Jones, who says, perhaps they're already there, but wondering if eating and drinking rehabilitation activities be included in ADL. Also, constraint-induced movement therapy, would this be included in upper limb?
So answering the constraint-induced movement therapy one first, this review is focused on function, walking, mobility outcomes and not on the upper limb outcomes. So obviously constraint-induced movement therapy is usually used to improve upper limb. Interestingly, we have found a number of trials that are looking at constraint of the lower limb, which is an interesting idea. So those will be included in this review. So constraining the good lower limb, which is not something I'd come across before, but that those trials will be in the review. Sorry, and what was the first part of the question?
She says, Natalie says, perhaps they're already there, but wondering if eating and drinking rehabilitation activities be included in ADLs.
So we haven't got the upper limb things in here deliberately. So we haven't got the functional tasks of using your arm in here because we wouldn't include a trial that was just focused on the arm. We absolutely would include a trial that was looking at holistic physiotherapy, which may include a mixture of upper and lower limb. So at the moment, everything like that is in that upper limb activities tick, because we're not so interested in that because of the focus of the review. So I think if people were having training to improve eating, drinking, etc., it would get incorporated into our box on upper limb activities.
Thanks, Alex. And a few comments coming in. Leslie Ann says you might want to include modalities of virtual reality and gaming.
Yes, we have got those in. If they're not up there, then we have got them in now.
Mm-hmm. And Leanne Carey says mechanisms that focus on learning, in brackets, she's got motor and or sensory approach, and the transfer of training.
Yeah, thank you. Yeah.
Great. Well, that's us got through all of the questions and the comments so far. There's a couple of comments just saying thank you for the hard work, and someone saying they can see how it would be beneficial to use the model for student learning and for clinical reasoning.